So I am going to follow that talk about optic pathway glioma and discuss tumors that occur in the brain and spine or outside of the optic pathway. And I recognize that I am the last scientific presentation of the day, so bear with me and I will try to keep it engaging, and we will keep going forward. So as I mentioned before earlier today, I'm a pediatric neuro-oncologist at the Children's Hospital of Philadelphia, and I also do clinical NF research for NF1-associated tumors. So what I'll talk about today is an overview of the types of brain tumors that we see in individuals with NF1, and also provide some updates for tumor research that's occurring outside of the optic pathway. But I thought I'd first introduce the two key brain tumors that we see in individuals with NF1 that occur outside the optic pathway and provide an understanding of what those are. So these are low-grade versus high-grade glioma. And low-grade glioma, which actually NF1 optic pathway gliomas are considered low-grade glioma. Low-grade gliomas are slow-growing tumors. They have less frequent cell division. They're more common in younger patients, and they're rarely life-threatening. And we think that low-grade glioma occur in 20 to 30% of individuals with NF1. This is in contrast to high-grade glioma, which are aggressive malignant tumors that have rapid cell division and are more common in older patients and are life-threatening and require aggressive treatment. Thankfully, these occur in less than 1 to 3% of individuals with NF1. However, they do occur at an increased incidence compared to the general population. So before I start talking about NF1 low-grade and high-grade glioma, I want to take a step back and actually talk about brain MRIs. So if you or your child has ever had an MRI of your brain, you may have received a report that talks about many different bright spots, T2 hyperintensities, changes that can often be quite distressing to receive if you receive that before you get a call from your doctor describing the results. And these bright spots that they're talking about are something that are called flare signal abnormalities, or FOSSI, or they were formerly known as unidentified bright objects. So in the left, let's see if I can use my point. Oh yes, perfect. So on the left here, you can see these kind of bright circles. Those are flare signal abnormalities. And we think that's due to fluid accumulation in kind of the outer layer of the nerve that causes these bright spots that we don't think cause symptoms. They don't go away with tumor treatment. They're just there and they can come and go. But if you look at on the right, in the brainstem there, you can see that this is actually a low-grade glioma or a tumor. And they look very similar. So when you have a brain MRI done and you have NF1, it's really important that not only a neuroradiologist, but an NF1 experienced clinician is looking at the brain MRI, because sometimes it can be very difficult to tell whether something is a flare signal abnormality or a tumor, and it can sometimes require additional MRIs as follow-up to be able to discern what is actually going on. So I just want to point that out, that it's important to recognize that some flare signal abnormalities can be incorrectly called tumor, and some tumors can be incorrectly called flare signal abnormalities. So I'll start by talking about non-optic pathway low-grade glioma. And to remind everyone, glioma are tumors of the cells in the brain and or spinal cord, so they can occur in both locations. We think that these occur in 5 to 10% of children with NF1 and up to 20% of adults with NF1. And these are often discovered incidentally. So someone may have had a head CT because they fell off the playground, or they had a brain MRI because they were having headaches. But compared to optic pathway glioma, less is known about the natural history of these studies. You heard Dr. DeBlanc talking about how many patients that have been enrolled on that natural history study, and they're learning more about who will require treatment and when. But for individuals, both pediatric and adult, that are diagnosed with a tumor that occurs outside of the optic pathway, it's really unknown how many will grow and how many will need treatment. And that's a very challenging discussion to have with your doctor when they're sitting there saying, I don't know what's going to happen. We're going to continue to get MRIs over time. But there's a lot of research that's going to attempt to address these questions that I'll talk about in a bit. So there can be different locations of non-optic pathway glioma. So on the left, you can see a tumor that's towards the top of the brain. In the middle, you can see a tumor that's in the center of the brain. And these tumors can be very circular, or we call them well circumscribed, or they can be more diffuse, like the low-grade glioma that's all the way to the right. The most common location of low-grade glioma outside the optic pathway is the brainstem. So that's the area of the brain that sits back here. The average age of diagnosis for brainstem glioma is approximately 7 years, and these occur in less than 10% of individuals with NF1. Most brainstem glioma are asymptomatic, meaning they were discovered incidentally or by accident. However, when patients do present with brainstem gliomas, it can typically be seen to be related to something called obstructive hydrocephalus, where fluid is normally supposed to flow from the top of the head down into the spine, but the fluid gets blocked and accumulates at the top of the head, and that increased pressure can cause headaches, changes in vision, vomiting, fatigue. So when patients present with a brainstem glioma and obstructive hydrocephalus, we actually typically move that fluid around so that those symptoms resolve. And that's done either through a shunt, which is tubing that goes from the top of the head into somewhere else in the body, or a procedure called an endoscopic third ventriculostomy, quite a mouthful, ETV for short, where the neurosurgeons make a tiny hole and help the fluid flow through a different area in the brain. If a brainstem glioma is identified incidentally without hydrocephalus or without other symptoms, we typically just watch, because while we don't know exactly how many tumors will grow or need treatment, we think that many of these tumors will never grow, will never cause symptoms, and will not require therapy. If there is brainstem tumor growth, we do recommend chemotherapy, and we less commonly use surgery because this is a very delicate area of the brain, and surgical interventions such as a biopsy or taking a piece of the tumor out can sometimes cause significant symptoms. So oftentimes we will not recommend surgery unless there's a concrete reason, such as a need to remove some pressure from the tumor that's there, or because we think that the tumor might not be actually a low-grade glioma. So when we think about treatment of low-grade non-optic pathway glioma in total of any location, including the brainstem, most commonly we're doing observation. A low-grade glioma has been identified. We recommend an MRI in 3 to 6 months to get a sense of if there's any growth potential or what the behavior is, but this is typically the most frequent initial approach. If the tumor is symptomatic or progressive, then we make a series of decisions about what the best treatment is for the patient. And this is really dependent on conversations with both neurosurgery, oncology, neurology, and the family. So the first question is surgery. Is the surgery safe? So when you have a low-grade glioma, if you are able to get that tumor out in its entirety with surgery, then that is usually curative, meaning the surgery takes the entire tumor out and it is unlikely to recur. However, depending on the location or the size of the tumor, sometimes those surgeries can be very risky, and there's a risk of paralysis or difficulty swallowing or some other neurologic deficit, not because of the tumor, but because of the surgery itself. So that's the first question we ask our neurosurgeons is the surgery safe, and are we likely to get the tumor entirely out? Because this is both important for quality of life and curative intent. We do not recommend radiation for NF1-associated low-grade gliomas. There is a risk of secondary cancer, so it is exceptionally rare that we would consider radiation at any point for these tumors. When we think about chemotherapy, we've already had that initial thought of, would surgery be safe and would we be able to get the tumor out entirely? If we're unable to do those, then we pivot and we say, what is the optimal chemotherapy regimen for this patient at this time? At present, intravenous chemotherapy is the standard of care for low-grade glioma, but there are clinical trials studying the role of oral chemotherapy, like what Dr. DeBlanc mentioned. So I know that Dr. Hemingway showed this slide, but I want to show it again with a slight twist as it relates to low-grade glioma. So when we think about clinical trials for NF1-associated low-grade glioma, the first phase, or phase 1, are typically small studies where we're giving a new or experimental medication and trying to find the most safe dose that patients will tolerate. Phase 2 studies are typically slightly larger than phase 1, and we're starting to ask that question of how effective is the drug of interest? Are we getting the treatment response that we want? Phase 3 studies are larger studies where we're looking typically at a standard of care therapy versus one of these novel or newer therapies and trying to say, is this new therapy equal to or better than our standard of care? So for low-grade gliomas, what many of these clinical trials are looking at is a partial response. So we're not trying to make the tumor go away in its entirety. Really what we're trying to do is make the tumor stop growing and shrink a little. And so partial response, or a reduction in shrinkage in tumor size from when the clinical trial drug was started, is typically the primary goal of many of these low-grade glioma studies that are outside of the optic pathway where vision is critical. A progression-free survival plot, which I'm going to show in the subsequent slides, is shown here on the right. And this actually doesn't have to do with survival. It has to do with, from the time the therapy is started, when do we next see tumor growth or a need for treatment. And so this overall represents the time that passes without the tumor growing or needing an additional therapy from when that first therapy was started. So as Dr. DeBlanc mentioned, carboplatin vincristine is at present considered our standard of care for NF1 OPG, and this is the same for NF1 low-grade glioma outside the optic pathway. This is an intravenous therapy that's given over approximately 13 months. And the reason that we use this as our standard of care is it's been well studied and well used for many years in the NF1 population. When we're thinking about giving chemotherapies to individuals that have a tumor predisposition syndrome, the last thing that we want to do is give a therapy that could potentially cause side effects or tumor development in the future. So we know that this combination of drugs is well safe. There does not seem to be a secondary tumorigenic or cancer-causing effect. And we know that when children are treated, or young adults are treated with this therapy when they have never received treatment before for their low-grade glioma, that at 5 years, the progression-free survival rate is about 70%. So what this means is at 5 years, about 30% of patients who were treated with this therapy for their low-grade glioma will have had subsequent growth or progression of their tumor, but 70% have not. Another intravenous chemotherapy that is commonly used for NF1 low-grade glioma is something called vinblastine. And this is also an intravenous medication that's administered once per week over a period of about 70 weeks. This is based off a phase 2 study, again, small studies that are looking to see if a drug is effective, that included 13 patients with NF1 low-grade glioma. The number of children without tumor progression at 5 years was 85%, so that means that at 5 years, only 15% grew or progressed. But what we found in this study is that almost half of individuals with NF1 had dose reductions due to toxicities or severe side effects that was actually more than we saw in the non-NF1 population. So this is why this drug is not commonly utilized as a frontline regimen, because of this increased rate of toxicity. Because of the successes of the MEK inhibitors for plexiform neurofibroma, there has been significant interest in the use of MEK inhibitors for NF1 low-grade glioma, not only because we're trying to find better and more effective therapies, but also because this is an oral therapy that doesn't require intravenous access, doesn't require as frequent clinic visits as many of the intravenous chemotherapies do. So I want to just state, so that everyone is on the same page, that selumetinib is approved by the FDA for the treatment of plexiform neurofibromas and not gliomas. So this is a common misconception that these drugs have received approval for NF1-associated gliomas, but at this time we do not have that indication yet. And there was a phase 2 study, so again, these small studies looking for efficacy, that looked at 25 children and adolescents with NF1 low-grade glioma, and half of these had tumors outside of the optic pathway. Why this study is a little different compared to the carboplatin vincristine study that I mentioned is all of the children that received treatment on this selumetinib study had received prior treatment for their tumor. So they had already had progression or not tolerated another chemotherapy before they received this selumetinib. So they had what we would consider treatment refractory or progressive disease. And excitingly, the number of children at 2 years from starting therapy without tumor progression was 96%. So at the time of these results, this was really exciting, and this tells us that maybe this is a therapy that is going to improve our care of individuals with NF1 low-grade gliomas. However, what was subsequently somewhat disheartening is that at 5 years, after coming off therapy, about 46% of children progressed. So about half of patients subsequently progressed and needed additional therapies. And we think that some of the reasons that the rates of response or rates of progression were different between carboplatin, vincristine, and selumetinib is this selumetinib study, the number of children at 2 years without tumor progression was 96%, but the duration of treatment was 96%. So that 96% actually represents the number of patients that had tumor control while on therapy. But then when patients came off of therapy, we saw that many of their tumors started to grow again. But as I mentioned, this was a different population of patients, so those who had already been treated before for their NF1 low-grade gliomas. And so when we tried to compare carboplatin, vincristine versus selumetinib using this previous clinical trial data, it's impossible because you have two different patient populations, two different sizes of cohorts, and actually two very different time frames for treatment. So the carboplatin vincristine study was conducted actually from 1997 to 2005, and that was a time when we were more apt to treat patients because we didn't truly recognize at that time that many of these tumors may not require treatment and may not ever progress. So to answer this question, and Dr. DeBlanc mentioned this study briefly, but I just want to highlight again that this relates to non-optic pathway tumors as well. To answer this question of whether or not selumetinib would be an appropriate or equivalent frontline therapy to carboplatin vincristine, we had this phase 3 clinical trial, ACNS 1831. And unfortunately, the study closed prematurely because we were not able to enroll for a number of reasons. But analysis of the treated participants is ongoing, and we're hopeful to derive some preliminary information about whether or not selumetinib may be an appropriate frontline therapy and equivalent in its efficacy to carboplatin vincristine. But again, as Dr. DeBlanc mentioned, it's unlikely we'll be able to say definitively based on the results of this study alone. So the next steps to address those knowledge gaps about the role of selumetinib for NF1 low-grade glioma, and also to improve our understanding of how and when to treat non-optic pathway low-grade glioma, is through, again, a natural history study. And the key questions that are remaining for both children and adults with NF1 low-grade glioma are how many individuals need treatment and why, how long after diagnosis is treatment usually started, what are the physical signs and symptoms of these tumors, and how frequently we should be getting MRIs. And there are no evidence-based guidelines at present for imaging surveillance or the initiation of therapy, meaning we don't know if it's best once you're diagnosed with an NF1 low-grade glioma to get an MRI every 3 months, 6 months, annually. What is that best time frame to bring you or your child back and to monitor your tumor? We don't know. So we have an ongoing natural history study to develop evidence-based management guidelines for NF1 low-grade glioma. When individuals are newly diagnosed with these tumors, we ask you or your parent if you'd be willing to participate, and over time we passively acquire a lot of information about you and your tumor. And what's also important about this study is we're not only looking at treatment outcomes, whether or not you need treatment, but we're also capturing information about neurocognition. We're doing neurocognitive testing, we're doing quality of life testing, and we're going to use much of this data to not only inform about NF1 low-grade gliomas, but to also use for other aspects of NF1 associated research, just such as neurocognitive and learning and other important NF1 manifestations. So these are the participating institutions. They're across the United States at present. And we currently, this slide is actually now outdated as of a couple days ago. We have 32 patients that are enrolled to date. About half are male and half are female. The most common age of diagnosis is between 5 to 15 years of age. The most common location, not unexpectedly based on retrospective data, is the brainstem. And all patients to date, out of all of the patients, none have required treatment with systemic therapy for tumor progression. So that aligns with what we're thinking, but it's nice to show prospectively that many of these tumors do not progress or grow. So I want to pivot briefly to NF1-associated high-grade glioma, which until recently, there was very limited data and limited understanding of these tumors. These are malignant aggressive tumors, which are very challenging to treat. And despite an increased risk in individuals with NF1 relative to the general population, there have only been a few very small studies that have been performed to date to inform us about how best to manage these tumors. So we recently, with the support from the Gilbert Family Foundation, completed a retrospective cohort study of 132 children and adults with NF1-associated high-grade glioma. Now, I said this tumor is rare, but now I'm telling you that we found 132 individuals, but we actually reached out to 47 institutions across the United States and Europe to get information about these 132 individuals. And what we found is most of these tumors occur in the cerebrum, or kind of outside areas of the brain, and that the distribution or location was relatively equal between children and adults. We also found that high-grade glioma are more genetically complex than NF1-associated low-grade glioma, and that the genetic changes can actually help to identify specific types of high-grade gliomas in NF1, and that the genetic changes in the tumors actually impact the behavior of the tumors and can potentially inform in the future treatment selection. And we were also able to provide more information about this new tumor type that's known as high-grade astrocytoma with piloid features. So this is a rare high-grade tumor in NF1 that resembles a low-grade glioma under the microscope, but has genetic changes that align with high-grade glioma. And we found that the behaviors of these tumors are less aggressive than other high-grade glioma, so they may benefit from an alternate treatment approach in the future. And the treatment approach for NF1 high-grade gliomas is quite variable. There is no standard of care, and there is no right answer at present. And it is unclear the benefit of radiation therapy and MEK inhibitors for tumors. So we really need prospective clinical trials to fully understand how to treat these tumors. And luckily, with the information that we got from this retrospective study from these 132 individuals, we were able to learn more about survival, about tumor behavior, and we were able to determine who should be treated on a trial and how to define what a successful treatment would be. And this data helped to inform the clinical trial design of an upcoming interventional clinical trial for NF1-associated high-grade glioma using mirdametinib in combination with radiotherapy. And I know I'm going over, so I'll talk very quickly. But the reason that this study is so important is it's not only going to tell us about if there is an effective therapy for NF1-associated high-grade gliomas, but it is also the first NF1-specific high-grade glioma study. And this is going to show that these clinical trials are feasible in our patient population and will hopefully encourage other drug companies and sponsors to help support prospective interventional clinical trials so we can continue to move the field forward and identify more effective therapies. So I'm very excited about this clinical trial, and it is going to be open in the very near future to enrollment. We already talked about NF-Extend, so I won't talk about any more of that today, but if you have any questions about this study, I am the chair of this study through the NFCTC, so I'd be happy to meet with you after this talk. So I may not have time for questions because I talked a little bit too much, but please find me after this. I'd like to get to know you, your story, and have to introduce yourself and answer any questions you may have. So thank you.